Good morning, Dr. Connard. Would you like to share video or audio so we can see you and check how the AD is? Is anybody from?
Yes.
We've got you, perfect.
Is it possible to zoom in just a little bit? So far, this like the outlet and stuff is distracting. Are there participants in it yet?
Yes.
Okay. That's better.
Okay. Welcome, everyone. Thanks for joining us. So this is Haley Southworth with the Ohio AAP, and I'm excited that you have come to our session this morning, Affirming Practices, creating supportive and inclusive spaces for Ohio youth with LGBTQ+ community and utilizing Ohio AAP resources to address risks and improve resiliency. So you have a good idea of what you're going to be hearing in the session, thanks to that. Our speakers today are Dr. Emily Harris, on site with us at Ohio AAP, and Dr. Leanne Connard, joining us virtually. We appreciate you both being here, and I will turn it over to Dr. Harris to kick us off.
Great. All right, actually, Dr. Connard is going to start with our talk, but just thank you for inviting us, and we're happy to be here.
And we're happy that you're with us before you started eating all the trick-or-treat candy, right? So you're not getting the sugar high. Anyway, so today we're going to talk about the objectives, employing best practices to create a safe, supportive environment for LGBTQ+ youth to receive health care. We're going to talk about utilizing tools to improve efficiency of detecting and addressing mental health risk factors unique to youth within the LGBTQ community, and also integrate protective factors and reinforce resiliency factors when developing the patient-centered treatment plan. Dr. Harris and I have no relevant financial relationships to disclose, and we will acknowledge when we're discussing off-label uses of medications and the treatment of mood disorders and gender dysphoria. So the first question we wanted to ask you to think about is using a child's chosen or preferred name is associated with A, decrease in suicidal behavior, B, reinforcing gender dysphoria, C, parent distrust of medical home, or D, delays youth self-acceptance.
So you can put an answer in the chat if you have an idea of how you might respond.
Ooh, everybody's doing great. So the correct answer is decreased suicidal behavior, and I'll show you those data here in a little bit. So we're going to start first with implicit bias because most of us have it, but how do we know what it is? So one of the things that you can do is if you Google the Harvard implicit bias test, they have a bunch of different tests that you can look at. One is like religion, race, but the other one is a transgender bias test. So implicit biases that we have that we know what they are, if you know what they are. The problem with implicit bias is we often don't know that we have them. And these different tests are ways to help us know what they are because we can't respond to them and think about how they act in our practice unless we know what they are and we're able to bring them to the forefront. So we'd like to show you a video really quickly of the Angry Santa, the car mechanic. Uh-oh.
I think it's just taking a minute.
Okay. It's going to have to share just a little differently.
Okay.
Can I just?
Yeah.
For a second.
I was flying from Jackson, Mississippi to New York for one client meeting.
You have audio.
I hear it.
Yep, we'll make sure you can all see it too. eyes. Can you all see this now?
I was flying from Jackson, Mississippi to New York from one client meeting to another one day, and I had to transfer in Memphis, Tennessee. So I get to my gate in Memphis in time for the transfer. As soon as I get to my gate, I hear those words coming over the loudspeaker the travelers hate to hear most. Ladies and gentlemen, there'll be a 45-minute delay. As soon as the words came out of the gate attendant's mouth, I hear a voice boom out from behind me. You're talking to us, lady? There's a guy sitting behind me who I would describe as angry Santa Claus. You know, he had a long white beard, white hair, wearing overalls, a flannel shirt, that had a car magazine in his hand. So I kind of chuckled to myself and went about my business working on my computer until it was time to get on the plane. And get on the plane, and sure enough, he was sitting next to me with angry Santa. And we fly for a couple hours until we get to New York City, and the pilot announces it's time for initial descent. Now, regular flyers know this is when airplane chat starts. So I turned to the guy and I asked him location to New York, expecting him to say he's got a family event or something. He says he has a business meeting. I said, really, what kind of business meeting? He says, well, I'm a radiologist. So immediately I felt guilt. It's like, how is it that after all these years of doing diversity work, I've stereotyped this doctor as a car mechanic? And so in my feeling a little nonplussed, I said, well, what kind of radiology? And then the hammer really hit. So he tells me that actually they've been studying the brain using functional magnetic resonance imagery and looking at which parts of the brain respond when people interact with different kinds of people. In other words, he's studying exactly the thing that I'm the most interested in. And had I not pegged him as angry Santa car mechanic and talked to him earlier, I might have saved myself 2 months of research on my book. So what we're going to be doing in this course is to be looking at unconscious bias from several different angles. We'll be hearing from myself or my colleagues, Kimberly, Rob.
So this is an example of kind of implicit bias, and taking the Harvard tests helps us understand where we are and what we need to work on as we think about our patient interactions.
Just a minute.
So the next thing we're going to talk about is creating a safe environment. And we'll look at the gender unicorn and think about this. So when we look at the gender unicorn, you can see, first of all, there's the third one down is sex assigned at birth. So people are either considered male, female, or other intersex. The next piece is gender identity, and that's where the unicorn has the rainbow he's thinking about, or they're thinking about. And there's multiple different gender identities. So a person can be female, a woman, or a girl, male, man or boy, and then other genders. So somewhere kind of in between, or maybe not on the scale at all. And you can see the arrow goes from like there being a circle with nothing out to a really strong arrow. And people can be somewhere on that range. And then gender expression presentation is how people present. So more feminine, more masculine, or maybe somewhere in between, androgynous. So if we think about feminine, often we think about someone with long hair and makeup and wearing a dress. So that might be the external presentation. Who people are sexually attracted to or who they're romantically attracted to may be two different things. And again, those can be on a continuum as well. And all of these things can be present at the same time. So a person can be assigned female at birth, but their gender identity may be male. However, they may be going to an all-girls school, so their gender expression or presentation needs to be female. Who your gender is and who you're sexually attracted to do not have to be attached. Next slide, please. So just a quick reminder. So when we talk about someone being cisgender, that's the sex assigned at birth, and it's when the sex assigned at birth and sense of gender identity match. So for me, I was assigned female at birth, and I feel that I'm female, so I would be considered cisgender. However, I think you met Logan yesterday, who Logan definitely is not cisgender. So a person who's transgender is where their sex assigned at birth and sense of gender identity do not match. And then we think about the real problem with this is that sometimes there can be gender dysphoria, and that's what we as pediatricians are trying to treat and help with. So gender dysphoria is discomfort or distress because there's a mismatch between biological sex and gender identity. And then the next slide, this probably is more of our friend Logan from yesterday, who gave a really nice presentation. So Logan is probably more one of these, gender nonconforming. And so gender expansive are kind of masculine girls and feminine boys who may not be transgender. So oftentimes you think of a tomboy, or a boy who likes girl stuff. Gender fluid, we know patients are people who don't have a fixed gender identity. They may be more masculine when you see them at one visit. They may be more feminine when you see them at another visit. And then a person who's non-binary may not identify as male or female, or may identify as a blend of both. So this was a study that the Human Rights Campaign did in 2018, looking at 13 to 17-year-olds. I think there were something like 20,000 in the study. And what this is looking at is sexual orientation outness. Now, the red means they're not out to anybody. The orange means they're managing it. So they may be out to some people, but not out to others. And then yellow means they're out to everybody. So if we look at doctors and healthcare providers, 67% of our patients are not out to us about their sexual orientation. 28% are managing it. Maybe they tell their primary care doctor, but not their pulmonologist if they have asthma. And then only about 5% are out to everybody. And then gender identity outness. Again, for doctors and healthcare providers, only about 61% are not out to their provider. 21% are managing it in some way, and 8% are totally out. But when we look at that, look at relatives, they're managing it with their relatives a little bit more. Teachers, more are managing it or are out to their teachers. Fewer are out to their religious community. So it's not uncommon for patients not to be out to us. So how do we help them how do we help them come out to us so that we're able to help them with what they need? So part of that is creating a safe environment. The goal isn't for us to push people to tell them, but it's for us to make a safe environment so they feel comfortable. So the safe physical space includes things like decor. Todd Parr has some nice posters where, everybody isn't the mom and the dad and the 2.5 children who all have blonde hair and blue eyes. It's more reflective of who we're seeing. Are the forms in the office saying, are you a male? Are you a female? Or is there another option? Or are you able to write in what your sex or gender are? Restrooms, are there male restrooms, female restrooms? Is there gender neutral? Is there family restrooms? What do we have that's safe, that lets people know we're thinking about their needs? And then safe people, show support. In the middle, there's the flag, the pride flag. And then again, examining our own implicit or unconscious biases that we have. I have a pronoun tag that I wear, and you see my pronouns are in my name thing, that my pronouns are she, her. And usually when I walk into a room, I'm, hi, Dr. Connor, my pronouns are she, her, so that people know they have the option. And then there are books that you could have in your office, like the Red Crayon Story, where you see that the blue crayon is actually in the red crayon jacket, as an example. And other things that you can have in your office include brochures. In your office, you can have pride flags in places. One of the things that Advocates for Youth has out is this middle booklet that you can print off the internet that says, I think I might be transgender. What do I do now? And there's also one, I think I may be gay, lesbian, whatever. What do I do now? And we really want to encourage patients to ask and tell, because it is good for them. So the other thing about the environment is it's really important for us to have training for our patient-facing staff. So we're very friendly and receptive, but they're not getting, if they're calling in and are having issues, that can be problematic. So we need to make sure our front desk staff are being trained. Again, making sure our forms and our labels, our medical records include this information. One of the things that we had trouble with was robocalls. The robocalls were using the name that the patient was assigned at birth instead of their chosen name. And what name do we put on mail going out to the house? Okay. So first of all, let's think about this case. So we'll come back to CJ several times. So CJ is a 15-year-old female who comes out to you in clinic. She mentions her family calls her Shay, but she goes by the name CJ at school. What should you do with this? Should you acknowledge it or ignore it? Put in the chat, please, what you think you would do. Okay, good. All right. So people are saying how important it is to acknowledge it. And this may be the patient testing you and seeing what, if you just blow it off and continue on, you may have lost your chance, your opening to have them come out to you and tell you what's going on. So it's really important to acknowledge what's going on and then discuss it. And we'll talk more about how to do that here in a little bit. So things that we can do to be accepting, making sure we're calling the patient by chosen name and pronouns, even when they're out of sight. So if the front desk person is saying, hey, Dr. Connor, so-and-so is here to see you, they should hopefully be using the correct name and pronouns, not saying the name assigned at birth. Try not to use the dead name. So sometimes people consider the name they were assigned at birth a dead name because that name is dead to them. And then apologize if you make an error and move on. Sometimes people will be like, oh my gosh, I'm so sorry I called you the wrong name. I'm still having a hard time getting used to this transgender stuff. When people call me Conrad, they just apologize and move on. They don't say, oh, I didn't know. But how to document this? So obviously for insurance and those kind of things, you need to have the legal name in there. But in the office, you can make sure that you have the chosen name to make sure that people are using that. And then next slide. And I see that there are a lot of questions coming up that we can address at the end. So the other thing that we do in our practice is correct each other. So if the nurse comes in and says, Dr. Connard, he is here for his, I'm like, wait, she? We correct each other to keep each other accountable. And then how do we identify people in phone calls, in person? So if someone's calling and they say, my name is CJ, and you can't find them in the system, did you used to go by a different name? Have you been seen here before? Doing those sorts of things. The other thing for pediatricians to remember is that these patients often have significant body dysmorphia. So there may be patients who refuse to let you listen to their heart or who have so much dysmorphia, they don't want you to see any part of them and may decline the physical examination. And again, using the chosen name of the youth who identifies as transgender can decrease suicidal ideation by 29% and suicidal behavior by 56%. This was in the Journal of Adolescent Health in 2018. So it does make it different, the name that we're using. So how do we ask? So the Centers for Disease Control, natal gender and current gender are the two questions the CDC asks, but those may not be appropriate for adolescents because just like everyone else, adolescents can be fluid. They can go through phases where they're more masculine or more feminine. So may not be the best two questions to ask adolescents. The other thing to remember is those adolescents, so some adolescents who identify as transgender, if we say, oh, are you transgender? They may say no, because they may be non-binary. They may consider being transgender different than being non-binary, gender expansive, gender fluid. So in our clinic, we tend to ask, do you consider yourself male, female, somewhere in between, or other? And I ask this to every patient because it's important to know that there are multiple options questions, and it shows that we're thinking about it and that we're interested and that we're a safe place to answer these questions. So our 15-year-old natal female, CJ, blurts out that she feels that she is transgender and is in the wrong body. What do you do? What questions do you need to ask? So we're going to talk a little bit more about this. So the first thing that's most important is giving unconditional positive regard that they told you. You know, I mean, we just looked at that chart that says 61% of patients are not out to their provider. So the fact that this patient decided to give you this information is really, really important. I'm sorry, am I missing something?
No, I apologize.
Oh, okay.
Error for saying. I apologize.
Okay. So, but they're also it's important to tell them that they're proactively addressing their health and that it's really important that they trusted you to hear them and you really appreciate it. The other thing, you know, is this information doesn't change how you feel about them. You still think they're an amazing adolescent or young adult, that you'll always respect them, and probably even more so for being able to give you this difficult information. And our job is to work together to focus on their health and safety. And we talk about how the conversation is confidential, but how safety is our primary concern. So the first response matters. So we use and restate their words. So you offered that you feel like you're in the wrong body. Thank you for trusting me to hear you. Can you tell me a little bit more about that? You know, how long has this been going on? Does your family know? That sort of thing. And then clarify your role as the primary care provider. One of my jobs as your pediatrician is to focus on your health and safety.
And when someone does come out or share something incredibly personal or private, it's a really hard thing. And I think Dr. Connor mentioned it beautifully about, you know, affirming that this is a generous thing that the child did with you or offered to you. And the NAMI is our National Association for Mental Illness, and it's for families, caregivers, and also people that do have and struggle with mental illness. And they came together and asked, you know, what do they want when they come to the medical home or their primary care provider or any medical provider? And they came up with these action steps, so to speak, and they might seem intuitive, but this is really the basics, like listen, ask questions, screen for the things that they are at higher risk for or anything that might be associated with their health, and evaluate, give treatment, follow up. And the bottom line, though, is to encourage and to offer hope that you know, they're making good health decisions. So thinking about, you know, a population that has, like, you know, gender variance or differences, you know, this supportive affirmation, safety, and then what are we going to do next is kind of the biggest priority when someone does come out. And thinking about this confidential interview, just to review, the technical definition of confidential information is anything the patient objects to you disclosing. So it's any information that they don't want you to tell. Breaking confidentiality, it can happen when the provider believes the patient is at risk of harm to themselves or others. And this is a conversation we usually have, but I think in this particular situation, it's a bit trickier, but really safety is the main focus. So, you know, you're going to manage these steps together. One thing to think about is, you know, sharing what specifically will be said. So if there is something that is relating to their health that you have concerns about, like focusing on that particular component and talking about it with the patient, and rehearsing like what will be said and what can't be said, is a helpful way to continue that confidentiality while keeping the patient safe. And one of the things, especially with suicidality, that I often do, because it is one of those times where you have to break confidentiality, is ask the caregiver directly, like if they've had any concerns about the person that is in front, like the patient, if they've had any concerns, and then offering some like general information, but then like specifically what you would do for this child to help safety plan and keep them safe. Giving the caregiver time to process and review kind of like what the next steps are going to be, but you do have to tell them and have to kind of give them time to think about what you had just said on both sides, the patient and the caregiver.
So this is an algorithm that we put together for patients who are coming out and what we should do. So the first thing we do is perform a safety screen and looking at mental health. And so I want to, we'll go through the rest of this later, but we want to start with that piece. So this is kind of where we're going through our talk today, is to figure out what we're going to do at each different section of the algorithm when it veers off. Next slide. So the top health risks for adolescents. So these are things that we're thinking about for LGBTQ youth. So as we're doing a safety check, thinking about these. So our LGBTQ adolescents, not just transgender, but LGB as well, adolescents are at higher risk for HIV/AIDS, probably about 4 times. Substance abuse, depression and suicide, sexually transmitted infections other than HIV, abuse and victimization, bullying, harassment. And I think Logan talked a little bit about some of this yesterday, or just not having friends, stigma and heterosexism. So, asking every girl who comes in, do you have a boyfriend? Assuming everyone is a cisgender, everyone who comes in presenting as female, assuming they're a cisgender heterosexual female. Racism, eating disorders and obesity. We definitely see a lot of body dysmorphia with our transgender patients. A lot of our patients may be homeless or in foster care, or at least couch surfing, staying with one person one night, someone else the next. And it's not uncommon when kids come out for there to be violence from a family member. Coming out, it can be a very, very unsafe time for our patients. And then a lack of access to care. They may be afraid that they can't find a safe place to see someone and let them know. So that's one of the reasons we're trying to create a safe space. Common mental health issues include depression and suicide. They're 8 times more likely than their peers to attempt suicide, 6 times as likely to be depressed. Anxiety, and the anxiety can be pretty significant, and they can be missing school because of it. Eating, like we said, eating and body image disorders, substance abuse, and they can have medical trauma, things like reparative therapy. In the city of Cincinnati, you're not allowed to send, it's illegal to send someone under 18 to reparative therapy. And what we think about by that is kind of when you think about pray away the gay, that sort of thing. But in the state of Ohio, overall, it's not illegal. So, putting a patient in reparative therapy, the American Academy of Pediatrics and Psychiatry both feel that this is very harmful to children. The other thing we need to think about is when we're seeing sexual minority youth of color. They often have pressure to choose between ethnic and sexual identity. They're even less likely to come out to their parents. They're more likely to have more mental health issues, more homelessness, high-risk sexual behavior, and higher HIV rates. All of the patients that I have in my clinic of 2,500 or so who are HIV positive are youth of color. So what we know that's really important is that the level of family rejection can really, really influence health outcomes. So if we look at, this is information from the Family Acceptance Project. And this is like best practices for suicide prevention. So when we look at families who are highly rejecting, these kids have much higher rates of HIV infection than kids who have moderately rejecting families, who have higher rates than kids with low rejection. So what I often tell families is, you don't have to be the person carrying the flag in the gay pride parade, but if you can just be neutral about your child, you really decrease their risk of bad outcomes. And that's one of our goals, is to move people to the low rejection in the family. Same thing for illegal drug use. Again, low family rejection leads to is connected with low illegal drug use. And then lifetime suicide risk. Look at how much it decreases if you have even a moderate to low rejecting family. So that's one of my goals in our clinic, is to help parents become more accepting, or at least less rejecting. And lifetime risk of suicide attempt is 41% for LGBTQ patients, whereas it's about 4% for the general population. Those who had experienced family rejection, 57%. Patients for whom a healthcare provider refused to treat them, and that this has happened in Ohio. Mental health condition that affects a major life activity, and very high in those who have been homeless. And it's even higher in young adults ages 18 to 24. So if you have those kind of young adults in your clinic, definitely make sure that you're paying attention to their mental health.
So this brings us to the topic of, what tools can we use, and what can we do in primary care. And as you guys know, the president of the American Academy of Pediatrics, as well as a lot of national effort within the pediatric community to focus on mental health and make sure that we're addressing this, as this is a direct moderator of outcomes for health, even in their adulthood. So there's, a lot of people know about the guidelines for adolescent depression in primary care. And I just want to review what the screening recommendations are for 12 and older, to be at least annually screened for depression. And if they do come in for like an at-risk or for-cause behavioral health concern as well, or if they have considerable risk factors, and being kind of like acknowledging or accepting as part of the community of LGBTQ plus is a risk factor for depression and suicidality, as well as anxiety. And using these instruments and tools these are time savers. They're conversation starters and time savers when you have a very little amount of time to address or ask. And it can also it's a lot easier with these internalizing disorders to have people write down their answers. So just an idea of another way. So these are some of the screens that people use in terms of like universally brief screens, but the PHQ-2 is our common one for depression, and anything over 3, you would do a PHQ-9. So the PHQ-4 is actually what's on the Ohio sports forms. So it's 2 questions about depression and 2 questions about anxiety. And again, scores for numbers 3 and 4. You would use like a general or a targeted anxiety screen. The Brief Scared was a new one to me a few years ago, where it has a few questions about anxiety, but then also a few questions about post-traumatic stress disorder. And this is it's a nice, quick, like 6 or 8 question questionnaire that's easy to fill out. But even the Vanderbilt, something as general as the Vanderbilt, we often use those primarily for ADHD, and then to kind of re-emphasize if there's like some oppositional or defiance features associated with it. But there's actually specific questions on the assessment that are really focusing towards like an anxiety or depression comorbid disorder, which are very common. So they're just different numbers in the 2 different teacher and parent versions of it that I thought was an interesting way to look at that as a brief screener. This is our PHQ-9. The first 2 questions are the PHQ-2. If you do not have significant, like more than half days or nearly every day in those first 2 questions, it's nearly impossible to meet criteria for depression. But if you do have one of those being positive, that's again why the PHQ-2 is a nice screener for depression. Then you ask the other questions, which are the diagnostic criteria essentially. So this can be used as a diagnostic screen. The modified version has these questions with the extra questions of how like a dysthymia or persistent depressive disorder. So has this been happening for a long time? And then also like more intense questions around the impact and the suicidality or lethality pieces of depression. And when you're looking at these scores, it's common because the scores over 10 have a much higher likelihood of the child meeting criteria for major depressive disorder. So that's often why over 10 is considered a positive screen. But really these kids 5 to 9 are often where you see them in primary care. And these are the kids where you're like, okay, well, you don't have depression, you're good. But actually they may meet criteria for depression. They may be functioning, they may be getting through the school day. It's just causing increasingly more difficult effort to do it. These are kids actually that the guidelines recommend to actively monitor and check in with them frequently. It doesn't have to be the pediatrician, but having someone check in with them frequently, like a coordinator, and reassessing them back in the clinic in 6 to 8 weeks. And if they're still between 5 and 9, they're actually considered to meet criteria or to be put into the criteria of mild and major depressive disorder and to begin evidence-based treatments. So thinking other things that can happen when, especially with a population that has high risk of victimization and even like internal concerns, but being able to screen if it's not MDD, but they have a high PHQ-9 score or something, is there any post-traumatic stress? Are you having nightmares? Are you afraid, or has your behavior changed differently? These are little kids that suddenly wet the bed when they've been completely dry for many, many years. Is there any other signs in their history that's kind of leading to some other mental health concern or problem? And then if their score is actually over 5, just to kind of reiterate this point, they have a very high risk of meeting criteria for major depressive disorder in the next 6 months. So these are still people that need to be evaluated and monitored over time. And just a quick look at this. I'm not going to get too much into the treating anxiety and depression components, but essentially like remission of symptoms is what the goal is with any disorder that's causing noticeable risk or problems. So I kind of put this chart together a little bit ago, but it just puts the PHQ-9, the modified version for kids, is like, validated in 12 to 18-year-olds. The GAD-7 is actually validated in 12-year-olds and up. So using it in younger kids is not really as informative or sensitive. The SCARED is more sensitive, and you can do this with the parent or the child plus parent to give to kids even 8 years old and up. And the severity is relative to the number. So these can be used as like ongoing monitoring as well to see how well the child's doing with the interventions being given. And interventions could be active monitoring, like we discussed, addressing the distress. These mild kids are, what is it? Is it acne? Is it a school problem? Like, what's happening? Let's see if we can do it. And then bring them back to see if they're getting better. Talking about brain health is a very good intervention, like, making sure they're sleeping, making sure they're eating. And then when they start getting in this moderate range, that's really when this evidence-based psychotherapy or treatments are recommended. And you can consider medication. But in some cases, you would do medication if they're having significant impairment. And then it goes up from there. And then when to actually, you don't have to refer everyone to psychiatry, but at least get something started. You can consult psychiatry if you have concerns. In Ohio, we do have some great options to get more information and have more training. So that's something to help pediatricians be more comfortable with what those evidence-based treatments are. We offered earlier in the conference, like the storage safe concept. So this idea of you screen, you advise, and talk to the family and talk about an emergency plan. This is like a safe kind of rhythm to have in your head about what to do when youth are presenting, and kind of thinking about depression. Well, 30 to 40% of people who have attempted to die by suicide or have died by suicide have had depression. The other 60% don't meet criteria. So it's still very important to, even if there's no depression, they're doing great, to ask about suicide. People with anxiety, especially panic, that's not getting better. They may not even tell you they're having a panic attack in the room. You don't know. So asking about like, what are the things that I need to do to keep you safe? You don't have to diagnose every single mental health disorder, but we do need to see, are you at risk of lethality? Depression is definitely the top modifiable risk factor. And looking and seeing if suicidality is even on the table. So taking a look at this, I just kind of compared, there's two different validated enough screens for pediatric use, and the ASQ, not the ages and stages questionnaire, but the little, actually it should be a little a, little SQ, is ask suicide severity questions. And, it talks about what we consider to be a suicide ladder. So the intensity increases as the questions increase. So, like a passive, some active thoughts, and then some behaviors, and have you ever tried? And if so, are you thinking about it right now? And this, the goal is like, if they answer yes to anything, it's considered positive. The Columbia, which I'll show you in a minute, is the suicide screen that has, the questions as well. You ask the first two questions, and if they're both no, you can move on. But then if the one is yes, you actually ask number 6, which is, have you ever done anything or started to do anything or prepared to do anything to end your life? Because often kids won't put that together with a suicide attempt or an attempt to die by suicide. And this is an example of like what the ASQ, is the little a, little SQ, looks like, and the questions. And this can be used on kids over 8. Actually, technically, this is how it's been tested. It is in kids 8 and up. It can be asked it should be asked with the older kids without the parent present, but there's even nursing scripts for this. And it depends on if you're in the inpatient units, the emergency rooms, specialty clinics. There's different forms for it. And this is the one for the outpatient primary care. And again, so any screen, yes, gets an intervention. So the brief suicide safety assessment should be done by somebody who's trained. So the ASQ can be asked by anybody, and then a brief suicide safety assessment needs to be asked by someone with like a social worker or a nurse practitioner or other mental health clinician or physician, just to see if a more comprehensive mental health evaluation is needed. And it should be brief and guide what happens next. So anyone that screens positive should be given a resource list, or at least some information about what to do next, which we'll get into in the end of the presentation. But the difference with the Columbia Suicide Rating Scale is, these questions are present, and we talked about them, but, if any yes, then we often talk about like, you should be referred. A lot of people are already in treatment. So it's kind of, have you talked about this with your therapist? And are you in treatment? Do you have a safety plan? Let's talk about it. Does it need to be updated? What's working, what's not working? And kind of having again, these are conversation starters, having a conversation about it. And then with the parent, in terms of like supervision and keeping people safe. And again, here's the hotline for the National Suicide Prevention texting and hotline as well. So I'm going to put this in. This is kind of a little bit, a lot to digest. So if you notice, like over here, there's like this yellow, orange, and red. Those are to indicate like a low, moderate, and high risk. So like the low, it's just thoughts about suicide, but still, that's like a very dangerous maladaptive response to stress. And they're telling you they need some other strategies on board. So increasing supervision, kind of paying attention, asking, but then, bringing it to the attention of mental health clinicians, informing families about evidence-based treatments to help with the stress that's driving that response, is the recommendation. For moderate risk, these are kids that have a method, or maybe they've attempted like over a year ago, but they're not acutely thinking about intent or a plan right now. They're still at a higher risk, especially for the impulsivity piece. And there's a dangerous association that they're making with distress and their options. So the idea is to definitely safety plan, and connect them with mental health professionals, or you connect with a mental health professional to make sure that they're aware and making sure that the safety is in place and that they're at the right level of care. And definitely as a pediatrician, reinforcing the strengths and protective factors that are going to help prevent or protect people when this risk is present. And high risk, those are kind of like scary, obviously, but they're a little bit easier. It's like, okay, you are high risk. This is clear that you need to be evaluated right now to see what level of care you need. It needs to be higher than right now, what we're doing right now. And, getting people to care, but safety planning, making sure they're not in your office by themselves, that kind of thing. So I just want to ask in the chat, go ahead and throw it in there. But what is the function of a safety contract? To A, best reduce liability and ensure patient safety. B, allow the patient to physically commit to safety. C, set up expectations to the caregiver and patient. Or D, to assess the level of engagement of the patient. All right, so I see a lot of C's. And I see any other answers, any A's or B's? All right, so I think you guys have seen some of this talk before perhaps, but that's okay. So we don't actually use the word contract because it's really a plan. Number one, kids cannot give informed consent by definition. They can assent, but they can't consent, which is what's needed in a contract. So what it does is it leads to your impression, it adds to your impression, and it helps you kind of assess how engaged the caregiver and the patient is with the process of planning for safety. And how engaged they are they ambivalent about it, kind of blowing it off or refusing to sign? What is their problem solving approaches to, what is their ability to problem solve really? And how open are they to trying something different or outside the box? This will give you a great understanding about what the risk is to this patient once they leave your office. And anticipation, when you can actually think about, when you're thinking and not in crisis, helps mitigate impulsive reactions. So if you can anticipate something, it becomes less of a surprise, and you're like, okay, I know what to do, and this is my plan. So C is actually technically correct too, in terms of having the written out plan of what is going to happen. And to make it quickly for primary care, if you're thinking about it, you have this patient in your room, the three basic things for a safety plan are restricting access to lethal means. So we talked about the Store It Safe project yesterday with lock boxes. You can put anything you want in there. And just to kind of throw it out there, teenage brains are incredibly impulsive and high risk taking by definition, that developmental stage in life. They should not have free access to alcohol, medication, or firearms, no matter how responsible they are, period. And thinking about it like that, what are we doing? So the other piece is are they going to be around anyone that may have this? Here's a lockbox. Here you go. If your kid's going to be anywhere in an environment where there's, grandma's medication, or if there's, the uncle that has firearms, whoever, it doesn't matter. Just these are things that can help keep your kids safe. And increasing the supervision is the second thing. And then coming up with a plan, either who are you going to call, who are you going to reach out to, and what are things that you can do to help yourself dial down the distress when distressing thoughts, especially thoughts about suicide, happen. And this is more information if you're interested. If you can tell, I kind of drank the Kool-Aid with the Store It Safe project. And I think it's really smart about providing this just to every family, how to reduce access to something that's potentially irreversible harm. Here are resources as well. We're going to touch on these again at the end, but I just wanted to throw it in here in terms of completing that safety plan. If the kid really can't think of 3 people to put or to communicate with if they're in crisis, because, phones die, it could be the parent that they're mad at or kind of having conflict with, somebody sleeps through the phone ringing, what do you do? And you don't really want the burden of responsibility to be on another child as well. So be thinking about like the supervision of that child who might be getting the phone call from the patient. But the text lines are actually pretty helpful. And the Trevor Project in particular is it's a wonderful online tool for youth or adults who identify with an LGBTQ plus community. And I'm going to give it back to Dr. Connors.
Okay, so we're going to go back through the algorithm a little bit. So you've performed your safety check and you've done all the things Dr. Harris just spoke about. So then the next question is, does your parent know about your gender? Or the caregiver who brought you in? And if the answer is yes, can we talk to them together about a treatment plan? And then if the answer is yes to that, here are other questions that we need to think about. Is the patient and or caregiver struggling with the gender identity? Oftentimes the kid has already gone through everything and has been on the internet and has figured everything out, but the parent is way far behind the kid and is starting to do those things now, so is struggling. It doesn't mean they won't be accepting in the end. It just means that they're not in the same place the child is. And then do all caregivers agree on how to handle this? If the parents are divorced, if a different relative has custody, do the parents agree that they need to do something about the gender identity? One parent may be like, oh yes, I totally support my child. We need to do what's best. And the other parent may be like, I think this is a phase. No, we shouldn't do anything about this. So, that may be an area of stress for the family as well. And do they have a support network? Sometimes people aren't able or ready to tell a family member or someone that they would normally confide in about this. So the people that they normally would have supporting them may not be there for them at this point. So thinking about that, and then this is the time when you may give them resources. Here in Ohio, Cincinnati Children's has a transgender clinic, Dayton Children's has a transgender clinic, nationwide, Akron Children's and Rainbow Babies and Children. And there are also some community-based organizations as well, like Equitas, which usually take care of adults. But those are places where people can get resources. But things to think about when we're talking about that. So then let's say that we can talk to the parent together. We ask if the kid, if we can talk about it, and the kid says no. Then we would talk about available resources, and then provide them when they're desired. But for every one of these steps, we want to make sure we're following up. This isn't something where we're like, oh yeah, see you next year for your annual physical. We should keep, just like Dr. Harris said, with our PHQ-9, we need to have active involvement and following up of these patients. So let's say that that the family isn't having any struggle. There are other things that we can do to help. For our patients assigned female at birth, sometimes helping with period management can really, really help with gender dysphoria. And that's one of the things, that's a totally different talk, but that's one thing to think about. So let's go back to the algorithm and let's say that the kid says, no, my family doesn't know about my gender. So then the next question would be, are you ready to tell them? And if the child isn't ready to tell them, then again, we describe the available resources and provide when desired and make sure we're following them up. The other piece that I like to talk about is there any other diagnosis that we could use to help the patient get some support and treatment? So for example, we already looked at the fact that these kids have a lot of anxiety and depression. Would it behoove us for us to talk to the parent with the child about, your kid is struggling, having some anxiety and depression, I'd like for them to be in therapy for that, and not discuss the gender identity piece. And then also thinking about heavy periods, that could be a way to help the child support them without telling the parent what exactly is going on. That doesn't mean the parent won't be told at some point. It just means the child isn't ready right now, and how do we help them? Be ready to tell them. Because remember, we talked about coming out being a very, very high risk time for a patient. And so then let's say the kid is ready to tell the parent. How do they want to tell them? Do they want to tell them in the office? Do they want to tell them? Do they want me to tell them? Do they want us to tell them together? Or do they want to talk to the caregiver after the visit? The Human Rights Campaign has a brochure about how to come out that can be helpful. So do they want to tell the caregiver at some time after the visit? And if they do, again, we need to make the follow-up appointment to see what's going on and to see, was the family accepting, are they struggling, that sort of thing. Next. So back to our friend CJ. So what if CJ's parents know but are struggling? How do we talk to them to help them be supportive or at least neutral, even if they aren't able to understand their child's identity at this point? And this can be a really hard thing. It can be, you're in the middle of a busy clinic and you're like, oh my gosh, how's this going to go? Next slide.
Sorry.
Oh, so we wanted to give you some tools to use because sometimes if you've thought about these ahead of time, you're able to go right into them. So,
some of the tools are actually pulled from a common themed idea. Like these are generally common situations that happen in primary care. And what we're trying to use are something that's going to be respecting the family and respecting their readiness level. So no matter what you get presented with, these are incredibly valuable, but it can be used when a kid's shutting down. It helps build alliance. It helps set an agenda. It helps deal with ambivalence, if they're help rejecting, everything, all these problems are happening, but nothing works kind of approach to treatment. Or if, there's family alienation, putting a kid at risk or putting a patient at risk, how do you respond in a respectful way that's going to help move the family forward and help them kind of take one step toward more healthy approaches to managing their child. And what these are like bits and pieces from motivational interviewing, cognitive behavioral therapy, these resiliency factors that we want to build, family-focused pediatrics. Dr. Lawrence Wissel put them all together in this soup called Common Factors. And I drank the Kool-Aid. I think it's great. I didn't even realize this is what I've been doing, but this is literally the skill set that is the easiest to kind of get quick, efficient use of conversation and interview and help a family kind of come up and align with a treatment plan before you walk out the door. Otherwise, it's really easy to kind of start spinning your tail and getting lost in the crisis. But these skills are actually specifically mentioned in the Promoting Mental Health in Children and Adolescents by Dr. Foy. And it came out a couple of years ago. I was embarrassed to see that had been on my shelf way too long before I cracked that book open. But once I did, I was like, this is so helpful. So it's the secret ingredient are these communication skills. And specifically with common factors, or actually really with motivational interviewing, is asking permission. So rather, there's this paternalistic view in pediatrics of I'm going to tell you what the problem is, and here's what we're going to do. Here's what you're going to do to fix it. It's more about is it okay if I share some information with you, or is it okay, or asking permission to do something, or offering information versus telling. So the other concept are ORs, open-ended questions, when you can. Affirmation, reflections are huge, especially when you don't have the right, you don't have the right answer, you don't feel like you're understanding. Just making sure that you understand what they're trying to say is incredibly valuable and validating. And summary statements, this is how I see things going. Am I on the right track? Can get you pretty far to help kind of rein in some conversations that are getting out of the comfort zone. And the art of the conversation is kind of truly believing that this kid is going to be okay and that they're going to get better. This hope increases everyone's hopefulness, by describing things realistically, reinforcing strengths that are inherent in assets that you see in the child and family, You want to empathize by listening very attentively with what they're saying and picking up on things that they may not be saying. Using the same language that the child is using is very, very valuable and can reduce your projection of what you think is happening onto what's happening, because you're going to miss stuff that way. And permission, asking permission before you do anything more in depth. You kind of need to respect where somebody is and what they can hear in the moment. Partnership with the family is the other P, and plan. Establish a plan for what to do, what actions to take, and if they're not ready, okay, how will you know you're ready? Getting them to actively think about what needs to happen next would be is a great skill to have on board. And asking it to offer information, but then asking them how the family thinks about it, or what they think is the correct way to go, or how they're approaching the situation is incredibly respectful, and it'll help you kind of keep going and have the family keep coming back. And many of you guys do this already naturally.
So the other piece, the other tool that we like to use is asking about experiences.
I'm sorry.
So when we ask about experiences, this is where you use your relationship with the family. You may have known these families for a long time, and you may have seen the kid for years. So for example, in CJ's case, understanding parent experiences is better than just telling facts. So instead of me saying to CJ's family, we know transgender is this, and it means this, and it's not surprising to me that your child came out to me before they came out to you, and blah, 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 blah. You help the family based on the history that you have with them. So parent, I don't think my child can be transgender because I never saw any signs of it when she was young. And so, I could easily say, well, usually we see two peaks, the young child or the, at adolescence is when we see the peak. That may not be helpful in the moment, but you may say, I remember that your older child was a really girly girl when she was young, and then we laughed together when she became a tomboy. Help me understand how your younger child's journey is different. So they've already had some experience with not gender being in one of the two boxes. So help us build on that and expand on that. And a lot of times you may have known the family to know the experiences that they've had, or maybe you ask, has there been someone in your family who's had a different gender journey or a different gender experience, and seeing how they've reacted to that. And then the next one is elicit, provide, elicit. And this is back to the asking permission to share resources and or information. And the only time you don't want to ask permission is when you absolutely have to give information. So let's say that the family says, I'm going to take CJ to reparative therapy next week. You really need the parent to hear the information you need to give them. So that is not a place where I would say, oh, would it be okay if I give you information about reparative therapy? Because if the parent says no, if you go forward and tell them the information, you violated their trust in you, So, but you ask permission to share resources and or information. So parent, I think he's just doing this to get attention. There's a lot of information out there, especially on the internet, that isn't very sound. Would it be okay if I gave you some medically correct information? And I've never had a family tell me no, and I do this at just about every visit. And the parent would say yes, usually. And you reply with information and then ask what they think of it. So, it would be unusual for a child to be doing this just to get attention. Being transgender is often stigmatized. People may, like Logan in the case yesterday, may lose friends over it. This isn't a way to get positive attention. And so you reply with the information and then ask what the parent thinks of that. Parent, I hear you, but I know my kid and it's all for attention because of the divorce. So the parent listened to you, but doesn't agree with what you said. So then, you say, no problem. I want you to let you know that I'm here as a resource for you. How will you know what to do or when you need to return? And again, don't use this if the answer can't be no. So then the values question protocol. This tool is often useful when the question has a factual part as well as a part that people may have different values around. It's good when you're asked what you would do if it were your child. And that never happens to us, right? So the parent says, I don't think I'm going to let my child join the GSA. It used to be the Great Gay Straight Alliance, but now it's the Genders and Sexualities Alliance that a lot of schools have. It's too much bad influence. What would you do if this were your kid? Next slide. Whoops, the next slide is missing. So anyway, so you would say, so the parents said, can you go back to the previous slide? So what would you do if this were your kid? So for the values question protocol, you would divide up what the question is versus what the values part of the question is. So, the question, so one of the questions is kind of about the Gay Straight Alliance or the Gender Sexuality Alliance. So that part is easy to answer. There's good data out there that GSAs actually improve school environment for all kids, not just LGBTQ kids. So having a GSA at a school is actually very positive, and it's a good thing for children to join. So there's the value, there's the question part, the factual question. So this is a good thing. But then the next part is the values part. What would you do if this were your kid? Well, my situation may be totally different than the parent's situation. My kids may go to SCPA where it's much more open as opposed to a rural school in Kentucky. So my answer may be different based on my child's experience, and I would often say that. So what I'll say is, I can't really tell you what I would do because our situations may be so different. However, if it's okay, I'd like to tell you what other families have done and what other families have told me, and then go into that, and then tell them about experiences your other patients have had with GSAs, how they've had a good experience and so forth. So that's kind of how you deal with that. I try not to answer questions if families say, what would you do if this were your kid? Because my values may be totally different than theirs. Next slide. Okay, so now we're back to, talking to them and going through the thing and seeing what we want to do next. So next slide. So if the parents aren't supportive, so CJ's back for a follow-up visit for monitoring of depression treatment, and he's ready to tell his parents and wants you to help him do so. You help CJ tell his mother, who's at the visit with him, and she becomes angry. She says this is just a phase and that CJ needs to get over it. And like Dr. Harris said before, part of this is helping the family, giving the family time to think and get used to the idea and ask more questions and understand what's going on. So what do you do if the parents aren't supportive? What would you address? What questions do you need to ask? And what should your minimum requirement be? So other tools that we use if the parents are having trouble being supportive is normalizing experience. So, with the other families I've talked to, this is not an unusual reaction. You're right where every other family is. Families have trouble sometimes accepting this, and it can take time to get used to. And you may have questions and you may need answers. Or it may be rephrasing information. So I hear you saying this is a phase, but has your child had other phases? Did your child go through, not to compare them, but, did your child go through a phase where they only wanted to eat peanut butter sandwiches? How did you deal with that? How did you get through that? You have to let your child go through a phase to make sure that it's a phase so it can either end or continue. And then finding common ground. And this is one that I use a lot of families having trouble. So it sounds like you're saying that you don't think you can use the child's chosen name, but you're going to try to use your child's old nickname. And the other one that I think is really important with finding common ground is, we're both really invested in CJ's health. You brought CJ here to see me today. Obviously, the health of your child is very, very important to both of us. And if the family isn't agreeing to the name or the pronouns, I tend to use your child a lot. So we need to move forward together. And then talking about how we're going to move forward and what the plan should be. And again, this is a family we should see back very quickly. But then we also need to identify crises. If there's suicide risk, if there's risk for abuse, I had a parent slap the kid once in the middle of clinic when the kid came out. So, those kind of things, we still need to be clear and direct and remember our role as reporters in these situations. Next slide. So the next thing I want to tell you about, and you can download this, it's an excellent resource. It comes in a couple different languages. There's also one that's specifically for Mormon families. But this has, it's the Family Acceptance Project, and it has behaviors that increase risk for mental health problems, and these are behaviors to avoid, and behaviors that improve well-being. And sometimes families think, oh, if I do X, it'll make it better for my child. And these are actually things that they've studied and asked kids about, and it actually is best practices for suicide prevention in LGBTQ youth. So next slide. And this is what the front of the booklet looks like. But again, you can download this off of the website. If you just Google Family Acceptance Project, it will come up, and you just have to put in like your zip code and your email address, and you can download and print it. It's an excellent booklet. And I do often show families those 3 graphs with the people and how acceptance can really decrease poor health outcomes. And that's in that booklet as well. Next slide. So we can also have ambivalent families who aren't fully connected to the plan. So we tend to use open-ended, summarizing, activated participation. What thoughts do you have about what you need to provide knowledgeable support for your child? I tend to ask about spiritual struggle and religion because I have a chaplain who works with me in clinic, because sometimes families may have come from from a strictly religious background where that may be one of their issues. So, would that be something that they would like to talk to someone about? And then resisting, help seeking versus ambivalence. It's a common human experience when considering and attempting behavioral health change. Past counseling wasn't very helpful with this issue, and you want to support your child to be an independent and confident adult. Next slide. So again, we've kind of come to the end of this. So up at the top, so if the family and caregiver is struggling, and if they're not in agreement, do they have a support network? These are all the things that are really, really important to keep talking about and bringing them back and seeing how things are going and making sure the child's safe. A lot of times families will go home and they'll think about things. And often once the child's told the family, the burden has come off the child, but now has set on the family, has set on the parent. So you'll see a child coming in who's stressed and anxious, and then they finally tell the parent. And then you see the kid's spirit lighten and all the weight come off of their shoulders. And then the parent all of a sudden has this big weight on their shoulders, and they're having to go home and think about it and what they're going to do. So realize that can be happening.
So go ahead. So thinking about like what to do. Oh, I guess I'm getting an echo. But thinking about how to, reinforce resiliency, not just with the patient, with the family, with yourselves, with your staff, kind of thinking about how to bring things into that are specific for this family into the treatment plan. We talked about a lot of different things, but one thing we haven't talked about specifically in a lot of spaces is, what is good mental health? Like, what are we looking for? Afebrile is easy, like normal blood pressure is easy. The rash goes away. The kid's going to school, but what does mental health look like? And you can throw that in the chat if you want to do a word. If anybody's fancy and knows to annotate, I won't go through how to do that, but you're welcome to do that. So we talk about this, but what are we actually saying? Because we use mental health like a mental health disorder. So sorry. So I see the ability for distress tolerance. Anyone else? Resilient. And resilient is, and I won't pick on you, Kathleen, but I would ask, like, what is that? What does that mean to be resilient? Skills needed to adapt to adversity in a healthy manner. Confidence, but not arrogance, right? Great. Just another minute. So thinking about having good mental health is this regular experience of effective practice, because you're right, like sometimes some of them are inherent in personality, but often they're practiced. You practice good physical health, you exercise, you eat nutrition, you do sleep, you do things to help your body stay healthy. And it's the same with mental health, kind of having confidence and courage, adaptability, cheerfulness, optimism, being able to focus or concentrate on something. You need a harmony, kind of being able to kind of roll with what's happening, but just kind of radically accept it as well. Hardiness, like you can keep going, and social connectedness. These are things that are regularly and routinely practiced with mental health. Another way to look at it is these protective and resiliency factors. So in order to have mental health and be able to practice all of those things regularly, these are some components that need to be, or that are shown to have positive effects on resilience. And this is why attending school and functioning in a positive way in school is so incredibly valuable for youth, which this pandemic has hit the reset button on for an entire year, if not more, for some families. But being able to like have social skills to seek help from others and have that connection happen. Like I need help, I'm going to ask somebody else. Like that's a developmental piece that happens, which is a resiliency factor versus handling it all themselves. Being able to be optimistic and being able to kind of have a coping strategy. You know, when I'm upset, I will talk about it. I could go out for a walk. I could go play a video game and distract myself. Like, what are things that they can do? What are things that they can think about or, you know, actively move toward, or different ways to manage stress. Emotional regulation, I think we're going to see a lot of distress around emotional regulation, especially with this generation of virtual experiences and social media, being able to edit, delete, and affect people with words. Self-control and emotional regulation are going to be extremely important to teach and to emphasize in the future. Being able to engage in behaviors and have form caring, supportive relationships, not just with family, but other adults, is incredibly important to build resiliency. And these safe, supportive, like nurturing relationships, they not only like buffer adversity when it happens, but it proactively like builds these social emotional skills that lead to resilience in the face of future adversity. So like being able to come back to home base. We talk about attachment theory, like at the very basic level, when they're 2, or like even before that, when they're 9 months and they have like that stranger anxiety, and then they come back to home base. If they kind of get a little bit more brave as they get mobile, and then they have this rapprochement when noxious stimuli, parent leaves or whatever, like they come back to home base and get kind of secure again. And this is just repeated in a bigger fashion as they get older, and their natural supports and who their home base is. It can be the parent, but sometimes it's not. And having that caring person who they can go back to and get good information from and support is incredibly valuable in terms of resiliency and being able to get through something very difficult. It helps with like self-regulation, executive functioning. It's a core life skill. So thinking about just generally overviewing what we talked about here, from primary care, safety management, how do you identify risk, identify protective factors? You got to think about it, stratify it, explain it to the family, and recommend a response in 6 minutes or less, because you have to actually examine the patient too. But we all are aware this is the one time where it is like the asthma exacerbation in your office. This is a crisis, and it's important to kind of ensure that you're doing things safely and following like what we've been now trained to do. So using those tools like that can help pick out if lethality might be present, engaging the family and the patient with the safety planning, like what are the triggers that could lead to these thoughts again. And I have a different slide next about like more about how to get this information quickly. But what are their strengths? What do they do well? I remember in Logan's story about, when the pandemic hit and the parents had, there were siblings that were younger, and then feeling responsible and taking care of them was a strength. Like it was something that they needed to do, and they were kind of channeling it for good, a way to manage the distress and to help their family stay strong. Developing communication paths, whether it's like texting or talking or just sitting silently in the room, is like a different way of kind of looking at how to do communication paths. And then sharing this decision with a family with the idea of supervision, communication, but then reducing access. Often we talk about like, taking the door off, or no doors are unlocked, or the family's going to check in visually every 15 minutes, or some interval of time. It shouldn't be regular, but an interval of time in some way. These are all things that are decided in the room, like together. Thinking about how do you educate them about like what are the risk and protective factors? Dr. Connor mentioned many things that people are at higher risk for with their health and safety and their mental health as well, and how to help kind of get that safety net around the kid that much stronger to know that this isn't their fault. This isn't something that they should be managing on their own, that they can come and get good information from you. Some of these are like not validated. They're a little bit on the Stanley Brown method, which I was super happy about, but I had written these out when I was talking about safety planning. So like, just to kind of get into it a little bit, actually I'm gonna do, oops, wow, that was fun, sorry. It was a very sensitive mouse. So it's funny. I think I actually probably should talk about these in reverse, but the safety, or when someone discloses that they have the suicide risk, just to kind of hit it a little bit more, what was happening the last time you had thoughts, or when are you most likely to think about dying? This is actually helpful to offer those like individualized things. So if they say when I'm in my room alone at night, or if I'm in my room for more than 2 hours and I'm not distracted, or like kids can be very clear about like when it's more likely to happen. And then you can kind of develop some insight around, or they can develop insight around what they need to do to mitigate that risk. So leave the door open, things like that. Delaying impulsive actions. So in cases where there are interrupted attempts or aborted attempts, or inferred, like they almost like they were thinking about it, what stopped them? How long did the thoughts or that decision that they could make, how long was it there before the thoughts went away? What helped it go away? They can actually just come up with their own safety plan quickly. You don't have to do it for them. Actually, it's better if they do it. Any help-seeking behaviors. These are, again, protective factors. Like, did you tell anyone? Was it a secret? Was it discovered by accident? Or did they proactively do something? So often people think that it's like a manipulation or attention-seeking behavior. Yeah, they're telling you they're not okay and we need to do something. It is not manipulative or negative in any way. It's the youth is saying, I need help. And then offer actually to, if they disclose something in your office, like, is this something that you've talked about with your therapist, and kind of reining back in the evidence-based treatment and the treatment team to help make this like a community or team decision about what's going on. And then aligning with a safety plan, like what would be an ideal way that someone could help support you and keep you safe if thoughts of dying, wanting to die return, is really the core of a safety plan. And the cool thing of these, like I wanted to touch on it, we talk about addressing the mental health diagnoses, kind of thinking about what are some things that they can do to keep their body safe, some coping strategies that lead to them being able to manage their own mental health and their own risk, thinking about problem solving skills, and just actively checking in. I think this idea of follow-up is life-saving. One of the core things with suicidality is hopelessness or feeling alone, isolation. The idea of you giving it attention and bringing them back in to make sure they're safe is therapeutically powerful. And I think that is often underestimated within pediatricians, how important it is for you to say, I want to see you back in my office to make sure you're okay. These are wonderful resources from the GLAD PC guidelines, as well as the Store It Safe program through the Ohio chapter of the AAP. And if we had time, and I think we might actually, hopefully, I wanted to show, this is something that sometimes I'll show in my office. And I am looking and I am, oh yeah, we have a link. So these are, just coping strategies. And I'm going to do this other one first and then come back to the one I just showed you. But these are things that you can just like coach the patient, even if you don't know what to do, if you don't have you don't feel confident with like the amount of mental health disorder, distress is happening. Everyone's too dysregulated to kind of follow through with a plan. These are things that are like brain health, easy to teach, can literally regulate the brain again in the moment. Actually, I've done this a couple of times in my office when I'm like, we're getting nowhere because everybody's just up in arms and dysregulated. But the idea of grounding techniques, I mean, grounding is kind of bringing that dysfunction and dysregulation to a place that is tolerable and something that they can handle. And back to that thinking brain once they can regulate and kind of calm down again. This one is a great handout about walking in rhythm. So with like a traumatic experience, like the fight or flight pathway is kicked in, and to get that calming rest, digest, parasympathetic nervous system activated, literally taking a walk, that rhythmic walking and movement, hearing drums or playing drums, dancing, hearing music, these are all extremely physically grounding techniques. It's a coping skill. Mental things that can happen is, anchoring these mantras of just because I have a thought doesn't mean I have to act on it, or just because this is happening doesn't mean it's going to happen like this every single day. These are different things that a therapist can coach the kid with, but then also this is something easy that you can teach in your office too. Soothing, like these sensory things about humming a favorite song or making a list of people who love you, or having, what do you have gratitude about? The five senses are often used to get that core brain to regulate again. Listing 5 things you can see, 4 things you can feel, 3 things you can hear, 2 things you can smell, 1 thing you can taste, or even the color Roy Biv of the rainbow. Go through the rainbow and name items in the room of each color. And these are things that can happen. You can do it by alphabetical animals or reverse alphabetical, whatever, just something to help keep you focused. But that time is not just distracting. It kind of gives your brain time to regulate and concentrate on something so that you can think again.
Do you want to switch the screen?
I'm going to ask Haley to help switch the screen. I think I can do it, but I still want my backup. We'll see if it opens. Oh, I have to launch. There it goes. And thanks for my mouse. So it will prompt me, I think, too. No. Of course, it didn't prompt me this time. Do I stop or just?
You can just
a new
click
share?
new sheet.
Perfect.
That one. Mhm. You can click play in the corner.
I get really mad when my brother hits me a lot. I don't like it when you say you don't want to play with me. When I'm mad, my brain can get a headache and it can start hurting. Your blood keeps pumping because you're like really mad. And you start to get sweaty because you're getting really, really mad. And when you start getting really mad, you turn red. When your body can't really control yourself, mad just takes over your body. I just get out of control. It's kind of like if you had a jar and then the jar would be your brain and then you put glitter in the jar and that would be how you would feel. If you shook up the jar and the glitter went everywhere, that would be how your mind works. And it's like spinning around and then you don't have any time to think. And you sometimes punch stuff and people when you don't really mean it. When I get angry, I feel it in my heart. I really don't like when I get angry. The amygdala really reacts, but the prefrontal cortex tries to keep it down. When I feel like I want to, get really angry. Yeah, I just sometimes, take deep breath. First, you find a place where you can be alone. Then you find some way to relax and calm down. When I need to calm down, I take deep breaths. I breathe in through my nose. Sometimes I close my eyes or just take deep breaths. It's coming down, it's not moving. It's slowing down and then it stops. And the heart becomes slow and then it goes into your brain. It's like all the sparkles are at the bottom of your brain. My brain slows down and then I feel more calm and then I'm ready to speak to that person.
All right, so thank you for indulging me. Sometimes I'll even put that on to explain deep breathing as I'm going to go get my scared screen from the other room or while they're filling it out. I find that families will say that they're going to watch it, but they don't until you just show it in your office. So if you need to go see another kid, or if you need to kind of go get your social worker or someone to kind of help manage whatever's happening in the office, this is a very useful little short video. And I'm sure people have other ideas and options that they do as well, but this is one of my favorites, so I wanted to share. But sometimes this can be hard. This can be hard on us too as providers. So I just wanted to make sure that we're all kind of leaving in a calmer space. Not that we were angry, but I'm going to pass it over to these are some other websites for healthcare providers that offer wonderful resources. And I know Dr. Conrad has a few, and then we're going to open it up for questions.
Yeah, so the Human Rights Campaign has a ton of information, pamphlets, booklets. Some of them are in English, some of them are in Spanish. All of them are free to print out as you need them. GLMA has some cultural competence webinars that are good. Physicians for Reproductive Health has some e-learning modules. And then Advocates for Youth has those pamphlets that I showed you earlier. Next slide. And then we're getting ready to take questions. Next slide. So I wanted to let you know that Saturday, November 20th is Transgender Day of Remembrance. So far this year, I think 69 or 70 transgender people, especially transgender women of color, have been murdered in the US. And so Cincinnati Children's, I know, will be having a service at noon that day to remember all those who have been lost. So it really does make a difference what we're doing. And I highly recommend the Trevor hotline, the Trevor line as well.
You should go on it, like anybody who hasn't been on it before. It's really neat the way they set it up and how they do it in a safe way to protect kids. It's great. All right, and we have some questions, I think. So the source for the posters, if Conleth could unmute and say, unless that question was answered.
So I'm pulling together,
Okay.
it looks like some are on the slides, so
Yeah.
the ones that include the 12 ways to practice grounding, the rainbow grounding. So we should be able to share those links in chat.
Okay. And thinking a lot of people did put some questions in chat, and how do we have like a list, or should I just scroll
I've been
through?
trying to grab a list,
Okay.
so I can give those to you for answers, and then if anyone has other questions, please feel free to keep popping those in. So I'm gonna start actually with one of the first questions that wasn't addressed. Do you encourage apologizing if a mistake is made with a name or pronoun? Someone shared that they have read that some of the community objects to apologies because it puts a burden of forgiveness on them.
I saw that question, and that's really interesting because I'd not heard that. And I have some people in the community on my team, and we tend to tell people to apologize. But it's not a prolonged apology. It's just, oh, sorry, CJ. Parents call him Shay. He goes by CJ if you're like Shay. And then he's like, it's CJ. Oh, sorry, CJ. I respect your name and pronouns.
Yeah, I think it's taken more of a tone of like a polite formality versus like a deep, like, you need to forgive me piece. Like it's up to the person whether or not they forgive you. It's interesting.
And the other thing I'll say about dead name is a lot of people use the word dead name. So if I transition and my name were now Larry, I might consider Leanne my dead name. But some people in the community are like, but we're still alive and we're still here. So some people will say it's their former name. And then the same thing with preferred name or chosen name. Like I prefer chocolate over broccoli, but if I have to eat broccoli, I can. Whereas chosen name is probably a better term for that because you really have chosen it and it's not just preferred. You really want people to use it.
The next question was regarding confidentiality. Do you have any advice on documenting in the patient's chart their preferred name or pronouns, especially when parents are unaware or not supportive?
So I think that's an interesting question. My social workers tend to hide all of their notes for patient confidentiality reasons. And it's really interesting because I was talking to our informatics person. He's like, why do you even need to put the name in the chart at all? Why, this patient, this patient, this patient. So I've taken to doing that a lot of the time. So at the top of the chart, obviously, is the legal name and that thing. But, instead of saying CJ or Shay, he, him, they, them, this patient is here today for depressive symptoms. they have been having trouble sleeping, they've been having this, they've been having that. This patient is here with their parents, and just using kind of that sort of thing is what I would probably tend to do if the family isn't aware of what's going on. Because you definitely don't want to out them by the medical record.
And then one other question, in your experience, how honest are adolescents answering the questionnaires about their suicidal thoughts? I think that Dr. Harris came right as you were covering the chart. And how do you recognize if they are not being honest? And what do you do then?
Yeah, so clinical judgment is tremendously important. And depending on they're adolescents, so they're depending on their mood, depending on their immediate experiences before walking in your office, like it could be any reason. They may not be honest. And honestly, sometimes they even exaggerate or kind of put all threes down for their responses. But no matter what is on that paper, they're still communicating something to you. So if they even put zeros down for everything, and you're looking at this person who is not engaged, their grades are failing, they're not getting to school, they quit the soccer, they quit the whatever team, they're isolating from even their own friends. Even if their score is a 0, I'm still going to notice that this is happening and kind of offer it. So using those common factors to be like, I noticed that you didn't think, you may know this as a depression screen, so you put all zeros, I think you're depressed, but this is what I'm seeing. Like, what does depression mean to you? Or, how do you see this being different? Would be one way to kind of address it with the patient directly. Or they might just be, which honestly, every time it's happened, the kid has been right, assuming that the adults aren't going to take it seriously or aren't going to do anything anyway, or they know their parent is not going to be engaged with the idea and the treatment. So it's a conversation starter. It is not the answer, because you're right, it is depending on what the kid says.
And I tend to I basically only take care of adolescents. And for the most part, I find them to be honest about what they're talking about, especially after they've known you for a while. At the first visit, they may not know you. So things tend to fall out over time. And if you're not asking the right questions, they're not going to answer them. The other thing is I will have, I may ask questions in front of the parents, because if I say, how's your mood been? The kid may say, oh, it's this. And the parents looking at them going, you've been staying in your room. You've been yelling at everybody. What do you mean your mood's okay? So getting that information as well. But one of the things that I ask every kid after I have the parent leave the room, when I'm in the room with them alone, besides talking about, confidentiality and what I can keep confidential and what I obviously can't, as a reporter, I always say, is there anything that we talked about or that you didn't feel anything that we talked about that you would answer differently without your parent in the room? As an adolescent medicine doctor, I take care of a lot of kids with eating disorders. And I find that kids who are purging will often minimize their purging. But then after the parent leaves the room, you probably get a better answer to how much they're purging. I still don't believe it's correct, but it's probably closer to what the truth is than when the parent's in the room.
And especially with kids that have probably had the screening tool done before, it really depends on how seriously you take it, will influence how seriously they take it, to throw it out there too. It's a great question.
And then just one last question, kind of referencing back to the medical record, and what do you do about the EMR if there's no space for the preferred name? It's really technical.
Yeah, that's a really rough one, because I know that our Epic allows you to have a space for that. I'm not sure how I would do that in an office that doesn't have that ability. Is if there's a space where you can put notes, we also have this FYI flag that we can put in that comes up, if a kid is like if Dr. Harris has somebody who's a flight risk or something, that'll come up. But then I have an FYI flag. It's a transgender tracking indicator that says, for the front desk staff who may not be opening the chart, it says, FYI, please, this patient is transgender. Please call him CJ. So that comes up. So maybe there's a different place you could put that.
Okay, we have one more question pop into the chat if we have a moment.
Yeah.
From Dr. Garner, an early slide made a distinction between romantic attraction and sexual attraction. How often do you see those as being distinct? He asks because for younger tweens, have found it helpful to ask them to whom they are interested romantically. Is it useful to ask tweens about sexual attraction instead?
So that's a really good question. And one of the things that I want to say is because people have a label doesn't mean they don't have the behaviors. So for example, if someone says, I was assigned female at birth, I'm female, so I'm cisgender, I'm attracted to females, that doesn't mean that I shouldn't be asking them who they're attracted to. And again, so I'm attracted to women, I'm romantically attracted to women and physically attracted to women. And I'll get back to your question in a minute. But the point I want to make is they could be having a sexual relationship with a person who produces sperm. So if you're sitting in your clinic and you've got a girl who says she's lesbian, is it possible that she needs birth control because she's having sex with a person who produces sperm? So again, making sure that you're not just going by labels, but actually asking about behaviors. And I think the difference romantically, emotional attraction and sexual attraction is actually different. Some of our patients consider themselves to be asexual, so they're not really sexually attracted to anyone, but they may have romantic or emotional attachments to people. And the other thing that I didn't say, I'll have a kid come in who goes, oh, I'm demisexual, aro, whatever. And even I, who do this work all day, every day, sometimes I have to be like, oh, tell me what that means to you. Because some people may be not emotionally attached to people, but may be sexually attracted to someone. So they can be two different things. But again, asking about behaviors and asking what that label means to them is really, really important. Does that make sense?
That was helpful for me too. So great question.
Yeah. I mean, we don't want to miss, treating people who need treatment, who need testing or treatment or that sort of thing.
And I think we touched on it. Gender dysphoria is a diagnosable condition, but it often looks like depression and can be physically pointed at the physical body, so that like body image distortion piece is very important as a pediatrician, because they could be self-harming. They may not want to show you. I think coming from a place of, my job is to keep your brain and body safe and healthy. And if you're comfortable, I just want to see if there's anything like an infection or how well the skin is healing to make sure that you're okay. Is an approach not like I'm going to take pictures and go show your parent, which is kind of like what they might be thinking. But it's really, no, my role is to make sure that if you need medical attention, you're here. Like, this is what I do. So please, let me help with the medical pieces, is a very useful strategy. And if not, then okay, describing what it would look like if it were infected would give that kid information, respecting that if they've had a trauma, they don't want you to see that you still are focused on their safety and health.
And I think one last thing that I would say is we see a lot of kids who have dual diagnoses of autism and gender dysphoria, being transgender. So if you have a patient who's on the autism spectrum, don't count out the possibility that they could have gender dysphoria and ask about it. And again, if you're seeing a kid who has eating disorder symptoms, they're restricting, they're binging, they're purging, make sure you're asking, do you consider yourself male, female, somewhere in between, or none of the above, to make sure that you're getting to the bottom of what's really going on.
Great. Thank you so much for all of this information, for answering the questions. Anything else from our experts today?
I think it's one of the times when it happens, but it's probably infrequent, much like suicidal or kids in major mental health crises. When they happen, it's kind of a game stopper. And part of that is because we don't have our own safety plan planned out of how we're going to manage it when this happens. So we're hoping to give information that can help you feel more prepared to address things, feel like you're doing the patient a good service, feel like you are being the best healthcare provider for this family and child, to have good health outcomes, and the plan ahead of time is huge. So how you're going to handle it with your staff, with your your office culture, the environment, your approach, having these questions, those key questions of what gender, or do you consider yourself male, female, or both, or somewhere in between, or other. How do you have these key questions about gender, to respect that this might be part of the reason why they're presenting with frequent abdominal pain and what you find out to be school refusal, or they suddenly had a worsening in their mental health or avoidance in situations. This could be part of the reason that if you don't ask, you're going to miss something incredibly important that's going to be critical to the child moving forward. So you guys, I love pediatrics, that. And it's such a great position to make such a huge impact on child health outcomes. And I want to pass it off to Dr. Connor. So I learned a lot from you. Thank you for doing this with me.
And I would just like to say thank you, everybody, for coming. And I would like to thank my former Pittsburgh resident, Dr. Harris. You did a great job. And happy Halloween, everybody. Safe costumes, safe travel, safe candy eating.
Yeah. Take care. Have a great weekend.
Right. Thank you, everyone. So the information to claim CME and MOC credit, the link is in the chat box, but it will also be provided via email, as well as the link to where slides and recordings post-meeting will be found. So you'll be able to access all of that. If you have any questions, please let a member of the Ohio AAP team know, and we'll be happy to assist you. But thank you for being part of our annual meeting this weekend, and I will echo those wishes for a happy and safe rest of your weekend. Thank you.
That was so good. Thank you.
That was fun. We'll give you a call, Leanne.
Okay, bye.
Great.